I'm going to start my talk on heart failure for the family physician. And I also call this talk Heart Failure Update for the non-cardiologist. Mr. Chairman, let me begin by saying that heart failure is not a disease. Now, this may come across as a very shocking statement for you, but let's look at the data. Heart failure defined is a problem with the structure or the functional capability of the heart either to fill the ventricle or empty the ventricle. So either to fill or to empty. If you see a patient with heart failure, see whether he is less than 75 or more than 75. If he is more than 75, your causes of heart failure are either ischemic heart disease, hypertension, valvular heart disease, atrial fibrillation, and that unknown category that I was talking to you about. Now, heart disease comes with various risk factors. People are hypertensive, people are diabetic, people have cholesterol, and it's been known that the comorbidities of heart failure, for example, a diabetic patient is 33% likely to get heart failure as compared to atrial fibrillation, chronic obstructive airway disease, and patients with chronic renal failure. So they go hand in hand. Now look at the data, that if a family physician treats hypertension appropriately, he can drop the incidence of heart failure by approximately 50%. And if you treat the heart failure appropriately in a diabetic patient, this ratio goes down by 52 to 56%. If a family physician treats a patient with heart failure aggressively with hypertension post-myocardial infarction, this figure goes down to around about 80%. The importance of maintaining a blood pressure at the family physician point of view is evident by this study in 2004, that even if you drop the diastolic blood pressure by 2 millimeters, you can drop the incidence of ischemic heart disease by 6% and the incidence of heart failure by 15%, just by 2 millimeters drop in diastolic blood pressure. If you see a patient with atrial fibrillation, he will have lost approximately 30% of the cardiac output. So a patient who is not in atrial fibrillation and suddenly becomes short of breath, he has developed AF, he loses 30% of the cardiac output. Moreover, we know that in this day and age over here of rheumatic heart disease, an untreated valvular heart disease will lead to approximately 81% of heart failure if it remains untreated. And the biggest cause, myocardial infarction, you have a dead muscle over here. Approximately 45% of patients developing heart failure. We always call it in UK, if the heart muscle is dead, it would not contract. An easy way to remember is, dead meat don't beat. So a dead cardiac muscle will not beat. That's what the problem is. So heart failure has a cause like hypertension. It has a cause like atrial fibrillation. It has a cause like valvular heart disease and ischemic heart disease. The end point of all these problems is heart failure. That is why we find that the heart failure is a common end point for many diseases of cardiovascular system, and it's the end result. So that's why I say heart disease, heart failure is not a disease. Heart failure is in fact the poor management of a disease. If you don't treat hypertension, it will lead to heart failure. If you don't treat ischemic heart disease, it will lead to heart failure. So heart failure is the end point of a poor management of the disease. The incidence of the heart failure increases with age, and as you become a bit elderly, both male and females are more likely to succumb to heart failure. Same is the case with the prevalence at any one point of heart disease, of heart failure, that we feel the elderly patient population are more than likely to develop this problem. And these patients, especially the elderly patient population, is likely to get on readmitted over and over again to the hospital. The incidence of 3 months admission is around 30%, that an elderly patient is likely to get admitted to the hospital within 3 months is 30%. At 5 months, this figure goes up to 50%, and an elderly patient is likely to have been readmitted to the hospital within 12 months at 70%. This is how important age is a factor to it. Now over here is a trajectory of heart failure disease. you have your first incident point or event in which the patient becomes short of breath and is admitted to the hospital. The patient gets discharged, and here is where the family physician comes in. They manage the patient by diuretics, ACE inhibitors, angiotensin-converting enzyme inhibitors, aldosterone antagonists. The patient remains stable. Patient loses compliance, gets on readmitted to the hospital over and over again. By the fourth admission, the patient is heading towards end-stage heart failure, and that's the point in which the patients usually die in the hospital. So the role of the family physician is right from the first event of the heart failure right to the end of how the patient is going to succumb ultimately. Now, whenever the patient gets admitted, the likelihood of his coming out of the hospital alive drops by 50% per admission. So after the first admission, on the second admission, 50% of the patient would have died. On the third admission, 50 more. On the fourth admission, 50 more. So your role as a family physician is to keep the patients out of the hospital, because hospitals don't treat heart failure very well, family physicians do. The prognosis of heart failure in UK is bad, as all over the world. And you find that the mean survival is 3 years from the diagnosis. So today, if somebody is found to have heart failure, within 3 years, he is going to succumb to end-stage cardiac failure. And that is why the guidelines that we're going to go through about are going to be very effective. Now, heart failure comes by many names, etc. And now we're going to show you how things have evolved in the nomenclature, how the diseases are being managed now, and what's the latest in heart failure management, especially in the community. We find people say this left and right heart failure, forward and backward failure, systolic diastolic failure, high output, low output failure, chronic or acute failure. But the bottom line is that the patient is breathless. It doesn't matter whether it's valve, whether it's ischemic heart disease, whether it's hypertension. The bottom line is the patient is always breathless. Now, the patient starts his journey from being normal to being asymptomatic and ultimately having refractory heart failure. But how do I know what your patient has? So what you do is that you write to me that, dear doctor, I think this patient has heart failure. The first question that comes to mind is, what's the physical capacity of the patient? And the physical capacity of the patient is done by New York Heart Association criteria. Very simple criteria, very simple nomogram. Class 1 is when the patient is normal. Class 2 is when you have minimal symptoms on maximal exertion. Class 3 is when you have maximum symptoms on minimal exertion. And class 4 is when you have symptoms at rest. In the community, you will be dealing with patients with class 1, class 2 and class 3 patients. You will be referring all patients with class 4 symptoms because they are not fit enough to be managed at home. But how do we understand what heart failure is all about? I usually tell my students that the anatomy of and physiology of a failing heart is based on a tale of 3 organs. And if these 3 organs are working properly, the patient is never going to heart failure. The first organ is the lung, the second is the heart, and the third one is the kidneys. The lungs communicate to the heart communicates to the lungs. The heart communicates to the kidneys, and if the kidneys fail, there's a strain on the heart. So let's vision it in the form of a pipe which has 3 sections, 1, 2 and 3. Each section denotes either the heart, the lung and the kidneys. If you block the pipe at any point, you'll have a back pressure. So if you block the pipe over here, the heart gets affected. If you block the pipe at the heart level, the lungs get affected. And this becomes very apparent in the practical way of how we treat heart failure. Supposing the patient's kidneys fail, the patient is not able to excrete the amount of urine, and that leads to a strain in the heart. Then if you develop left ventricular hypertrophy, you develop LVF. When the heart fails, you develop pulmonary edema. So that is why this axis of heart, lungs and kidneys is vitally important. You see that you cannot have a patient who leaves The curse of a heart failure, if the heart is involved, or the lungs are involved, or the lungs are involved, and the kidneys are involved. So each one of these is interrelated to each other. Now, just imagine the lungs empty the blood into the heart. The heart is working properly, it excretes blood through the kidneys. No problem at all. But how do we assess how the heart is functioning? Easy way to remember is the heart can never remain empty without blood. There has to be some blood in the heart at some time or the other. Now, the more the blood remains in the heart, the more heart dilates. So in an ideal situation, whatever comes into the heart should go out of the heart properly. If you have more blood coming in and less blood coming out, the heart dilates because of volume in the heart. The more dilated the heart is, the more volume of blood is in the heart. Now, if you imagine ejection fraction is the amount of blood which is pumped out from the heart. In a normal person, the ejection fraction is around about 60 to 70%. It's not ever 100%. A moderately reduced ejection fraction is when you have between 41 and 49%. And a reduced ejection fraction is when you have between 49 and below, 40 and below. So ejection fraction is the amount of blood which is pumped out at one point of the cardiac cycle. Normally it's around about 60 to 70%. Nobody gets 100%. So the heart, what happens is blood comes in, blood goes out, but if there's more blood going out than in, then you have a problem. Now, systolic heart failure is when the heart muscle becomes weak. The muscle which is contracting the heart is weak. That means it's got to push harder to get this blood through the kidneys. But if the blood is not being able to pump properly, the lungs get affected and you develop pulmonary edema. This is called systolic heart failure, when the pump becomes weak. If it's an engine, the engine is not firing on all the cylinders. This dilated heart and poorly contracting heart is what we call heart failure with reduced ejection fraction. This is the latest terminology that all the family physicians are now being encouraged to use as far as reduced heart failure with systolic impairment is concerned. Heart failure with reduced ejection fraction is when the heart's ejection fraction reduces below 40%. That means the pump is weak. Now, this is the heart in normal time. You can see the heart, all the chambers are contracting very well. This is the left ventricle, this is the right ventricle, and the atria below. In a patient who has a dilated heart, see what happens. This is a ballooned left ventricle. The heart is not pumping very well. The muscle is weak, so the lungs get affected. The patient becomes breathless. This is called heart failure with reduced ejection fraction, or mainly called HEF-REF. Let's go on to that. This is my picture back in 1995. I was a bodybuilder at that time. And as you can see that I was pumping weights and my muscles became big. I do not grow big muscles, but the muscles become thickened at any time. Then the thickness of the muscles is dependent upon the strain on the heart. The causes are either hypertension, AF, hypertrophic cardiomyopathy, or aortic stenosis. So the thing is, hypertension, age, hypertrophic cardiomyopathy, and aortic stenosis all lead to a thickened heart muscle. The heart does not grow more muscle, but the heart muscle becomes big. Human body cannot grow more blood vessels. So if the heart muscle becomes big and the vessels remain the same, that means there is more area to supply the blood to, but less blood supply. And that is why every patient with systolic, with left ventricular hypertrophy succumbs to ischemic heart disease at about 20%. This is a patient with left ventricular hypertrophy, and you can see that the heart muscle becomes thick. The heart size does not increase, but the cavity size reduces. The heart failure which is caused by a thickening of the heart muscle like this is called heart failure with diastolic dysfunction, in which the heart muscle becomes so thick that it's not able to relax properly. This is called heart failure with preserved ejection fraction. That means The heart can pump properly, but cannot relax properly. And because of this, the lungs again get affected with water, and you get heart failure from that point of view. The difference between hypertrophy heart is that your heart muscle is thickened as compared to the normal cardiac chambers. The poorly relaxing heart and with preserved ejection fraction is called heart failure with preserved ejection fraction. This is compared to the heart failure with reduced ejection fraction, and this is heart failure with preserved ejection fraction. The outcome is exactly the same, that you, from a dilated heart to a diastolic dysfunction, the management changes dramatically. The management changes because the heart failure problem is more of volume overload over here, and over here more of a pressure overload. Over here you need to control the patient's blood pressure. Over here you need to control the patient's volume. The three patterns of heart failure are very well seen. This is a normal status. This is heart failure with systolic impairment. This is heart failure with diastolic impairment. Now we know that ischemic heart disease and all these chambers cause these problems. Now remember, I told you this was the situation about 5 years back. At 27% of the heart failure was caused by unknown causes. Now it's called, this is because of heart failure with preserved ejection fraction. This was previously not known, and the treatment of this is not very clear either. The diagnosis and the prognosis of heart failure with preserved ejection fraction is as similar to that of systolic heart failure. Again, more in the elderly than in the younger patient population. It's more seen in the patients who are elderly. It is mostly seen in older women with hypertension and AF. So hypertensive elderly lady whose heart ejection fraction is normal, don't think that she may not have heart failure. She may have heart failure with preserved ejection fraction. And in fact, most of the people with HEF-PEF, which is heart failure with preserved ejection fraction, have a normal ejection fraction or near normal ejection fraction. That is why you need to be careful about this thing. And whatever the incidence all over the world, is now considered to be 50% of all heart failure cases throughout the world. The outcome is similar. In fact, the outcome is worse at times because you cannot realize what type of heart failure it is. The heart failure with reduced ejection fraction is when you have ejection fraction less than 40%. When you have preserved ejection fraction, it's around about 50%. And moderately reduced ejection fraction, it is around about 40 to 49%. These are more than likely to be diagnosed on the basis of ejection fraction, elevated BNP, and one of the causes on the echo that we see are either left ventricular hypertrophy or left atrial enlargement. That is again a domain of the non-cardiologist. The heart failure with preserved ejection fraction has many associations, including atrial fibrillation, obesity, psychiatric problems. So it's a rather conglomerate of causes rather than one specific cause. That is why we need to, when we are comparing heart failure with reduced ejection fractions to heart failure with preserved ejection fractions, the things which are common is aging, obesity, and elevated BNP. So don't send the patient away if the ejection fraction is normal but has signs of heart failure. The patient may have heart failure with preserved ejection fraction. This is a normal profile, elderly female, obese, sedentary lifestyle, and these are possible causes of HEF-PEF. These patients die of two things: sudden cardiac death and non-cardiovascular problems, because the heart failure with preserved ejection fractions cannot be diagnosed very easily. If a patient gets myocardial infarction, left ventricular hypertrophy, he can either develop a failing heart or with reduced ejection fraction, or a failing heart because the heart does not relax properly. All of these lead ultimately to cardiovascular death. The reduction of mortality has not changed, be it heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. But how do you diagnose it? The diagnosis is based clinically, without any problems, on either the major criteria or the minor criteria. The major criteria are over here. You have to have two major or one minor criteria to diagnose heart failure. As far as investigations are concerned, every patient must have blood tests done. Without these, people are not seen in the heart failure clinics at all. You have to have ECG, chest X-ray, echo, and a BNP. Very simply put, the heart failure patient cannot tolerate a very fast heart rate. The heart failure cannot tolerate a very slow heart rate. The classical signs of heart failure, which you shall be going through in a little while by my colleagues, are seen by the bat swing appearances that you see on the ECG, which is an ominous sign that the patient mortality is around about 80% in the hospital. Then you have to look at the echo itself. The normal heart, which is now a dilated heart, and the differences between either dilated heart or left ventricular hypertrophy is seen. That is the basis of our diagnosing whether this is a dilated cardiomyopathy, if there is no cause, hypertrophic cardiomyopathy in which the interventricular septum thickens up, or the restrictive cardiomyopathy in which the heart cannot relax very well. The BNP is a very important tool. It's being used extensively, but the diagnosis of heart failure on the based on BNP is overrated. The BNP is not the only isomer which is released. You have ANP released by the stretch of the atria. You have BNP which is released by the stretch of the ventricle, and you have a CNP which is released by the stretch of the carotid artery, carotid bodies. So BNP is what we are looking at. But how safe and how reliable is BNP? BNP, if it is 0, is very significant. That rules out cardiac failure. That is the use of BNP. But if the BNP is very high, there is an increased incidence of poor prognosis. The main correlation is that if the BNP is less than 100 picograms, that's the diagnostic criteria of excluding acute heart failure. So elevated BNP, poor prognosis. Midway BNP, we don't know other causes, and a very low BNP would indicate heart failure with reduced ejection fraction and can exclude it completely. Easy way to remember BNP is breathing near impossible. So BNP has a negative predictive value. How do you manage heart failure? I emphasize this because you have 5 symptoms: shortness of breath, edema, orthopnea, fatigue, and PND. Now, the first 4 are related to fluid overload. The last one is related to low cardiac output. So 5 symptoms, first 4 related to fluid overload, the last one is related to low cardiac output. The heart failure treatment, the mainstay of reducing symptoms is diuretics, diuretics, and diuretics alone. The symptoms will not get any better. As far as disease modifying is concerned, ACE inhibitors, beta blockers, aldosterone antagonists. Now, there are some non-pharmacological means, and there are some pharmacological means also. From your point of view, the first prescription that you use, remember the number 2. The patient's sodium restriction should be less than 2 grams. The fluid intake should be less than 2 liters. The patient should be advised to use 2 pillows. The alcohol intake, which is not relevant over here, should be less than 2 units. And the total calorie requirement should be 2000 per day. So the figure 2 is very important from your perspective of how you advise the patient what to do. The pharmacological means are ACE inhibitors, ARBs, beta blockers, digoxin, aldosterone antagonists, and diuretics. So there are 3 targets: angiotensin, noradrenaline, and aldosterone. We have to block all 3 of these to improve the prognosis of the patient. Now, in order to block the angiotensin, we use ARBs or ACE inhibitors. Whatever the cause, whatever the ACE inhibitor, does not matter which ACE inhibitor that you use. Now, I told you the median survival is 3 years. Once you use the ACE inhibitors, look at the survival, how it's prolonged. So your ACE inhibitors should be a part and parcel of every prescription that you use. Again, look at the kidneys, because the kidneys are very important to function. The second blockade is that of adrenaline, and that is done by beta blockers. But why should we use beta blockers when the patient has heart failure? Now, in order to understand that, I'll just give you a small analogy. I would just ask you guys to put your hands together like this. Your left hand, your right hand is your heart muscle. Your left hand is your coronary artery. Just remember that. Now see what happens. Now I would like you to contract your right hand fingers. Okay, that means you are squeezing your coronary arteries, correct? So when the heart contracts, your coronary arteries get squeezed. When the heart relaxes, the coronary perfusion occurs. What beta blockers do is they prolong the diastole. They help prevent the heart do this. If the heart is tachycardic, you'll see that the heart's blood supply is impeded. That is why we give beta blockers to all our patients to prevent the diastolic phase. This is very important, and no matter which beta blocker that you use, doesn't matter whether you use atenolol, carvedilol, propranolol, don't forget beta blocker in your treatment of heart failure. Now the third problem, the third enemy of the heart is with aldosterone. And we block this by giving things like aldosterone antagonists, which are called spironolactone and things like that. Now, if you give somebody spironolactone whose ejection fraction is approximately 40%, that figure is important. You reduce by the overall mortality by 35%. So the three things which are very important is ACE inhibitors, beta blockers, and aldosterone antagonists. The side effect of all this, all aldosterone antagonists, is hyperkalemia, gynecomastia, so you need to be a bit careful about it. Digoxin is very well used, but how effective is digoxin? Everybody uses it, but is digoxin effective in heart failure? Now the data shows that digoxin does not improve the survival. Amazing. But what digoxin does from your point of view is prevents rehospitalization. And from the primary physician's point of view, it's very important that the patient should remain in the community. And that is why digoxin is more used in the community rather than in the hospital itself. Diuretic therapy. Now, that is the mainstay of controlling the heart's volume. But the problem is that if you reduce the volume, the kidney function can go haywire. The only diuretic that you should use is what we call a loop diuretic. The loop diuretic, the most commonly used is Lasix, correct? Now Lasix is called Lasix because it lasts for 6 hours. Remember that. When Lasix came out for the first time, this is the only diuretic which lasts for 6 hours. That is why Lasix should be given twice in a day. One at 8 o'clock in the morning, one at 1 o'clock in the afternoon. Lasix once a day does not help the patient at all. You can be non-therapeutic, but in order to prove that, that's the way forward. There are two important factors which have come in the advancement of heart failure in the community. And the first one is Entresto, which I was involved in the trials of. Now, Entresto is used, and the other one is an anti-diabetic medication, SGLT2 inhibitors. I'm going to come to that in a little while. In New England Journal, we mentioned that if there is a combination of sacubitril and valsartan, if you give this combination in patients who have advanced heart failure, which are beyond ACE inhibitors, beta blockers, aldosterone antagonists, you will find that these patients improve dramatically. The overall reduction is around about 20%, and the clinical benefits are that 20% reduction in cardiovascular death, 20% reduction in cardiovascular mortality, 21% reduction in the first hospitalization. So what you are doing is preventing the patient to come in the hospital, because every time the patient comes in, the likelihood of his going out alive are reduced by 50%. So this is very important. This is a very expensive drug still, but all phases, all symptoms of heart failure seem to be very well affected with it. People are very happy. Diabetes has a comorbidity of around about 33% of developing heart failure in some way or the other. SGLT2 inhibitors is a new class of anti-diabetics which I think is being used over here a lot. The only anti-diabetic medication to date which is useful in the determination of improvement in cardiovascular death in heart failure is SGLT2 inhibitors. They not only reduce heart failure of cardiac death, heart failure admission after the additional admission, and other causes too. So if the patient is diabetic and has heart failure, rely on SGLT2 inhibitors. So what to do and when? So, though there are many treatment options for dilated heart with reduced ejection fraction, there is a limited data on what to do with heart failure on reduced ejection fraction or preserved ejection fraction. A simple nomogram with systolic impairment is rely on diuretics, and diuretics alone to improve the symptoms. Secondly, every patient should have an ACE inhibitor, a beta blocker, and aldosterone antagonist. If the heart failure worsens, add Entresto, and if the patient is diabetic, ask SGLT2 inhibitors. If this does not work, give me a call. I'll be more than happy to deploy a device for the patients. But that's very expensive. In our setting, this should be the mainstay of the treatment. If you have heart failure with preserved ejection fraction, in which the patient's heart is not dilated, you have to rely on treating the hypertension, slow down the ventricle so that perfusion occurs, treat the congestion, prevent ischemia, restore the patient in sinus rhythm, and use beta blockers to help slow the heart rate down. Because there is no guideline for heart failure with preserved ejection fraction. And that is the mainstay right now of identification of these patients. There is no control. We treat the comorbidity and control the symptoms. So, ladies and gentlemen, heart failure is not a disease. Heart failure is the end result of the poor management of the disease. Thank you.